Hey folks, we're back. I'm your host BKP. We are at Circuit World here in Blue Ridge, Georgia. We keep reminding you next week we're going to be at Sycamore Crossing.
Sycamore Crossing.
Now, for some reason, I seem to think I got to continue to remind you. Yeah. Even if you forget, maybe if you come out the front door, you'll say, "Oh, there they are."
Yeah.
All right.
But if we were there today, I'd have to be wearing a jacket.
You may have to wear a jacket a couple times. We'll be there next week.
All right.
Dr. William Whaley, Dr. Raymond Tidman. Can't start the segment without thanking Georgia Cancer Specialists affiliated with Northside Cancer Center. We appreciate you so much for the segment. Guys, welcome back. That's the way we'll say it. Welcome back. Yes. That's bold. We'll go. You have something you want to add?
I'm having a little seizure here.
You're trying to get it in. It's like the old TV pattern?
Yes.
All right.
Yes.
Some out there don't understand that. So, all right, your tie.
It has been 2 weeks since we
Absolutely beautiful.
Since we mentioned this.
Okay.
And you told me to go look for it. You don't remember this.
Ooh.
But I was listening. I drive back to Atlanta, as you know, once a week. I went down on Tuesday, came back on Wednesday. And I had a aching hole in my heart.
Rush Limbaugh.
This is a Rush Limbaugh tie, and there's nobody has filled that space on the radio that could shine his shoes. It is a black hole of 3 hours every day in the radio. And as the way the country's going now, I can think of him when Clinton came in, I can think of him when Obama came in. He would be in his glory right now. He would be having so much fun. And the people that are trying to imitate him are just not so good.
But there's a lot of men and women out there that do a great job on the radio that are trying, and I agree with you, and it doesn't mean that they're not doing a great job, but they're just that 12-3 is empty. And there's some others attempting 12-3, but for me it's just, I mean, so anyhow, but you're correct, because after Rush died, I said you said I have those ties, and I sent you in and said, go find one. That is a beautiful tie.
Yeah, it took me weeks to find it, between the lake and everything. Y'all, it's a personal story. You don't need to know that.
Hi, how are you?
Fair to middle.
All right.
Fair to middle.
Okay, ready? Let's go. You ready?
I am ready.
All right. This is a very interesting question, and when I was trying to talk to my wife about it, she had the foggiest idea what I was talking about, so we're going to be kind of slow here. First part of it's easy. My husband has lung cancer, doing well on maintenance with the Jimmy Carter immunotherapy drug. Now, we remember we've had patients here we've talked about 6 or 7 years just looking like us, taking that drug and going on about their business. So I am making the assumption that this has been going on for a while. In 1 week, he developed huge swelling of his abdomen and had 4 quarts of fluid, and that would have been liters, I guess, for the doctors, drained off 2 times in 4 days. Now that's a lot of fluid to come out of your abdomen, right? The doctors cannot figure out why he got this and say it's probably not his cancer. He had a good PET scan 3 weeks ago. So actually, probably not his cancer. What are your ideas? Well, when I started talking to my wife about this, she didn't have any idea what Ascites was. So Emily, show that first picture if you would, please. Now that is about 6 liters of peritoneal fluid. That looks like a 9-month pregnant man there. I'll tell you it's a man. This was a man. So within a week, everybody got a good look at that. So you see and you also notice that it looks like a drop of water. See, a baby would have some shape in there. So that looks like a big drop of water in the abdomen. Pull that down so people don't focus on it. So within 1 week, he blew up like a balloon. And there was water in there. So,
Ascites.
Ascites, yeah, we call it ascites. We're not trying to give too many big words, but okay, we call that ascites. But basically, in medicine, if there's an issue, you get tissue, is sort of a joke. And I always said your right hand should look like your left hand. If there's something in one breast and isn't there, go take a piece of it. Well, if you got fluid in there, you don't know what it is. It's just fluid. So here's what they did to him. And we put that next one up. It's kind of interesting. But they just take a bag, stick a needle in there, perfectly safe. You've got gallons of, and they took off 4 quarts of this water.
Wow.
Wow.
That's a lot of water.
That's a lot. Now, when this comes off, remember you got there where everybody can see it just one time? Pull that down there. All right, so now the water comes off. It's got lots of things about it. If you didn't do a real good job sticking the needle in there, you might have gotten a little blood that could be pink. But if it comes out looking like plasma, or like, looking yellow like plasma, and that's the way most of them look. Put this next one up, Emily. We've always got to have a chart, and these words aren't too big. So 81% of ascites is caused by...
What is that?
Cirrhosis.
Cirrhosis.
Okay, cirrhosis.
Cirrhosis. 81%.
81% of
It's
ascites.
caused, right, it's caused by cirrhosis.
Yeah, so if you're just
Okay.
bet man, what are you going to tell her? Probably something,
Right.
something with the liver, cirrhosis. All right. What percentage is cancer?
10%.
10%. What percentage is heart failure?
3%.
All right, so TB.
Tuberculosis
Yeah, all right.
is 2%.
So and
Okay.
pancreas 1%.
You have dialysis,
And other-
pancreas. So
other-
these are all the
That's-
possible causes.
Yeah, there are a few
But
more.
but cirrhosis is 81%. That's
81%. Okay.
okay.
You can pull that down so people don't look at it too much. So well, the first thing they're going to do with that tissue, that fluid, is they're going to pull it out, and they're going to check the protein in it and the protein in the blood. And there's a ratio between the protein in the fluid and the protein in the blood. It's not important what it is, but if it hits that ratio, it's 97% related to cirrhosis. If it doesn't hit that ratio, it's got to be something else. Okay, put that next one up, because this is a pretty picture. We did this back in medical school. This is the fluid. Some third-year medical student they gave him this, and he went off to the lab. Well, back in our day, he did. Now they do it in a professional lab. He put it under the microscope, and that's a bunch of bacteria. You can pull that down. So the causes of all this thing, you begin with cirrhosis, but it happened so rapidly that I think he probably had some underlying liver disease and actually infection that, boom, can make it happen fast. Otherwise, it's a slow process. A few months ago, he began to look like this, and then it goes up so slowly that people just don't hardly even recognize that it happened. Okay, put that next one up, because we've got to always have a complicated chart.
Yes, got to have the flow chart there.
Yeah, well, this chart is really, really, really complicated, because once you get past that 81%, to get into the rest of them, you have got a million ways to go. Yeah, pull that down. And so I'm going to tell her that the lung cancer and the doing well on the Jimmy Carter drug, keep that in your mind. Keep worshiping at that shrine. They have done this test already, and they've looked at it under the microscope, and they didn't see any cancer cells. And as I just showed you, only 10% are cancer anyway. He's got something that went on with his liver. Now, we don't know if back in the day, when maybe he smoked, he might have been a little generous with the alcohol. We don't know whether he had high cholesterol and was overweight and had a fatty liver. But there's lots of things that can give you occult cirrhosis that would never have been diagnosed.
Bill, are there any hepatotoxic drugs for lung cancer that he could have been on?
Sure, I've got a patient that just succumbed from one, and it happens to be the Jimmy Carter drug.
Yeah.
But he would probably be yellow, and it doesn't say it is. So yes, there are. It's unlikely to be that, but yes.
It's interesting you say, well, I trained up in the Midwest with a lot of Native American indigent populations, and alcoholism is very, very severe in that genetic group. So we constantly had patients coming in with severe cirrhosis and humongous bellies that we would tap, and their skin color is a little bit different. So when you saw their
you can tell. And look at their
eyes. You have to see their eyes to see their jaundice. But it was, we tapped a lot of tummies.
Yeah. Well, anyway, so basically at the end of the day, they're going to come to whatever it was. There are some cases of this. that are due to vascular things that have happened in the abdomen. And you can actually put in a shunt so that once you know that
Goes around the liver.
not malignant, you just put a shunt in and it actually just takes it out, puts it into the circulation, and it circulates, and then it goes out in your urine. And so I would tell you to focus your attention on the fact that his lung cancer is under good control. It's clear from the question that he's getting appropriate medical care. And my ideas are this is going to be a nuisance and not something that's going to complicate his cancer. There. But I can't help you more than that.
All right, folks, we want to thank you always for your questions. You can always send those to info, I-N-F-O, at FetchYourNews.com. Find us on social media also. Put in the subject line, Ask the Doc, and also find us on social media at Fetch Your News. Send us questions for the doctor. Georgia Cancer Specialist, affiliated with Northside Cancer Center. We appreciate you for this segment. So, question number 2.
All right. This question, I have 2 patients that I've seen in the last week that are in this kind of a category here, and there are some concepts about this question that are important for people to know and understand. So I'm gonna, and a lot of this is, some of the words are frightening to people, whereas the process is not too terribly frightening, if it makes some sense to you. My sister had a scalp nodule found by her PCP, removed 4 months ago, and diagnosed as a superficial skin cancer. So we know that there was something on the scalp. Must have gone in for a physical, and it wasn't one of these actinic keratoses things, and it wasn't some sebaceous cyst or something, because PCP had somebody take it off. Now, don't know what the pathology was on that superficial skin cancer, but the nodule returned, and the patient got to the hand of an oncologist some kind of way. So we might have something happened there. So the pathology reviewed at a cancer center, the diagnosis was changed to Spindle Cell Sarcoma. So that's the word sarcoma scares people because they hear, of the Kennedy kid who lost his leg, and all of these osteosarcomas. This is a skin sarcoma. That was removed, and a surgeon went back to do what they call a wide re-excision. Well, if you look at my forearm, I've showed you that many times. That big old scar is a wide re-excision of the melanoma. And you remember when my eyebrow was way up here?
Yes, I do.
That was a wide re-excision on my head of a squamous cell cancer. I've had about 6 or 7 wide re-excisions. They always leave you with a scar. But that's what they do, to go in there and get a big old hunk of normal tissue around the bad tissue so that theoretically and hopefully will not return. So wide re-excision is the proper thing to do to a malignancy, whether it's a squamous cell, basal cell, any other type of skin cancer that's occurred. Go on here and get it out, and then get a healthy hunk of meat around it. Now, they said the margin, wide re-excision, the margins are clear. What is your opinion? They say to watch and wait. Well, that's my opinion. I would watch and wait. You're in the hands of skin cancer specialists. I can tell you that the watch and wait, particularly if it had been a squamous cell cancer that recurred, and that's the most common of the skin cancers, they might have told you, even if they did that, go off and get some radiation. Then when you start talking about radiation, that scares people to death. So I was going to just say something about the radiation for skin cancers. You have radiation that penetrates deep into lung cancer and stuff deep inside your body, that penetrates. But skin cancer radiation is like, it's like you just put cream on it. It only penetrates millimeters, so it doesn't get to anything underneath the surface of the skin, and it kind of, you see all those are all potential cancers. It would clean that up. So the first thing I'll say is your sister's getting good care. If they come back and tell you that they want to go ahead and do some prophylactic radiation or radiation in this future, don't get frightened at it because it's going to be superficial. It's not going to be what you think of when you're talking about lung cancer, radiation, or something. And I think your sister's getting good care. And now we're going to go talk a little bit about sarcoma. So put that picture up and we'll get an idea of what
Bill,
we're dealing
before you
with.
get into that,
Yeah.
do you think in reading that question that the first pathology was sent off for an overread, or the second pathology is where they diagnosed
I think
the
it's
sarcoma?
probably the second.
Because clearly they missed the pathology on the first.
You see, I'm not really sure they missed it.
Okay.
Because if they did a shave biopsy,
Okay.
there may have been some squamous or something on the top of this nodule, and 4 months makes me think they were watching it.
Okay.
Not that they just sent him home. Well, put that up then, because this is what you're talking about. See this little thing there? Now, that's not, you see that? If you go stand in Ingalls and watch 50 people that are over 60 walk by, and you're going to see 2 or 3 of these. And see that one in the ear?
Yes.
These are both spindle cell skin sarcoma. Now, I got 2 pictures of them here, and we're talking about one. Let's go back to talking about sarcoma as a whole, because people are frightened of it. This is less than 0.1% of sarcomas, this little spindle cell of the skin. So when they took that word sarcoma on there, they threw it in with all of these heavy, bad diseases that you're talking about. The bone that Kennedy kid lost his leg. You have the children that get the osteogenic sarcoma, and they go down to Emory and they get chemotherapy, and they can preserve the leg. But anything in the body that is soft tissue, not skin and not gut, when it becomes malignant, that's sarcoma. So muscle when it gets that way, fat when it gets that way, bone when it gets that way is generally always called sarcoma. This little spindle, let's show that next. We always have to have a pie chart, don't we, Emily? Put the pie chart up there. So if you grab all the, if you look at the pie chart of sarcomas, liposarcoma, that's fat. That's these little fatty tumors. A lot of people have lipomas that are benign. Well, 20% of real sarcomas start out that way. Leiomyosarcoma is a lump on your muscle. How many people got a lump on their muscle where they tore their hamstring when they played track, or got hit in the arm with a baseball when they played baseball, and then there's a knot there? So the places that these things can occur, that the one where it says other right there, which is 28% of sarcomas, this spindle cell of skin or skin structure is in that, and it turns out to be less than 1% of all sarcomas. Pull that down, Emily. So now we can't ever have a cancer question without
Oh, you gotta have a graph. You gotta
survival curves.
Yeah.
All right, now this is 8 survival curves. It's really just 8 different types of these cancers. Got it up there, Emily? All right, the top line is whatever it was treated with surgery. In other words, when in doubt, cut it out. So many things I've said you don't want to bother with cutting. You don't want to cut up a lymphoma. You don't want to cut up Hodgkin's disease. You want to treat that you don't. There's no role for surgery in those diseases. Sarcoma, that's the role. That's where if you can get it out with a knife and get good margins around it, it's the way to treat it. So pull that down, Emily. That's the real short issue on sarcomas. Most of them are not like this skin cancer. This skin cancer, I wish they had a different name for it, so that patients who didn't go Google sarcoma and start thinking that my sister's got one of these. Got the
Now,
concept?
I want you to know that Bill he stepped on it just then, because in this day and age of cancel culture, he used the dreaded phrase, when in doubt, cut it out. Now, that's the surgeon's motto, and the internist will have your head for saying that.
Yes, he will.
Anyway, so
But if it's a
be
sarcoma,
praying for Bill.
Yeah.
Okay, so
Pray for me, yeah. So if it's a sarcoma, though, and
See,
you
I
get it
understand.
out,
I understand what you're saying because you I've been listening to you for years, and you talk about treatment,
yeah.
and very few times do you go to cut it out.
Right, take breast cancer. We want to
Right,
preserve the breast.
right.
Take a lump, do something else,
Right.
leave the breast on. If it's a sarcoma, get the thing out of there. And frequently, as these children now, you see them all the time on the Danny Thomas, whatever that place is called.
St. Jude's. Yes.
Where they go in there and they give them chemotherapy, and they take that sarcoma and they, remember, bring the ripples closer to the center. They give them chemotherapy first, bring the sarcoma down as small as you can, then remove it. So, but anyway, that's way beyond this.
Can I see your survival curves real quick? This also, I mean, you probably put these down already, but this speaks to our profession. You know, we show patients, here's the normal progression of the disease, and then here's the progression of the disease with treatment A versus B.
Diabetes.
Okay. So we show them the normal risk versus the adjusted risk according to our therapy. Why have we not been doing that with COVID?
Oh my goodness.
Okay,
All right,
so
now we're on. Okay, all right. So that was our segue into COVID.
hold on just a second. You slow down just a minute.
My program.
I know, but we're going to thank.
All right, go ahead.
We're going to thank Georgia Cancer Specialist Northside Cancer Center for this segment. We thank you for the questions. Now we're going to gently move into, take it away.
Well, he did it. He moved into. I was just going to say, this disease isn't over yet. You remember a few weeks ago we said we had 54 and then 56 deaths in Fannin County. As of today, it's 70. So that's been a big number of deaths that's actually been attributed, because that were residents here in the last 2 or 3 weeks. It added up the number. But this is the interesting thing. If you look at the total, here it is right here. If you look at the total number of cases in, now, how did that thing go here? Total number of cases in Georgia, you got 878,000 confirmed cases, all right? So if you've got, and the population of Georgia is a little over 10 million.
Right.
So that means that 8.7% of the residents of Georgia have been, quote, confirmed cases.
Positive blood test.
Yeah, that's what they, right now. Go to deaths. You have 17,000 confirmed
534.
deaths. Well,
Yeah.
if you just put those numbers on there like teach kids in 3rd grade, that means that 0.17% of Georgia residents have died of the COVID vaccine virus. 0.17. Now, that's not a terribly big number, but it's a bigger number than the number that die of the disease. 0.17 is 1/10 of 1%. I mean, but the fatality rate from the disease is so much younger than that. So why is that number there when the fatality rate generally is 1 in what, 20,000 or something?
Well, it depends on the age group.
Right, wait a minute, there's the answer.
Yeah.
Okay, your turn.
Well, I mean, this is a disease of the elderly and people with multiple comorbid problems. I mean, that's the group that's at significant risk. Now, even though that's a significant risk, of 100 that go into the hospital in the old days, 4 would die. Well, we have new medicines and new treatments, and I don't know what the current number is, but it's surely lower than 4. And if you do it across the general population, 99% of the people who get the disease, get better. So of all people, it's a small percentage, but if you want to really look at the at-risk group, it's the elderly above 65 with other medical problems.
All right, now let's go to who is getting vaccinated.
Well, we started with the elderly, and now 2/3 of our elderly are vaccinated.
Correct. And the people that are anti-vaccine people that are staunchly and are not going to get vaccinated are about 17% of the population.
17 to 20.
I want to ask a question.
Yeah.
Now, not this representative, okay? I'm not being secretive, not this representative. I want to be clear on that. I was at a lunch meeting Wednesday, and at the lunch meeting, a Georgia State representative gave a presentation on some things that happened down at the Georgia State Capitol this year. Moving right along, moving right along, the Georgia State representative said to this room that I was in that he had COVID. His son had it. I think daughter, wife, went through the whole house. Okay, had COVID, recovered. Talking about how serious it is. Then he went on to say he did not, will not, he has not, will not get the vaccine because his doctor told him, and this is on video actually, we video, his doctor told him, no, don't get the vaccine because he keeps getting checkups and blood tests. It says, no, you don't need to get the vaccine.
I would support that position. I tell my patients who survived the disease that their immunity is probably superior to the vaccine.
That's what he said. The doctor told him, his doctor told him, is his antibodies that he has are actually, his risk factor is lower than if he had the vaccine. Am I getting that correct?
The number of people who have had truly positive COVID infections that were hospitalized, that later on got infected again, is minuscule.
Small.
More than small, minuscule, and all of them survived.
Yeah. And I think where I'm going with that, and I'll turn it over to you. I think where I'm going with that is there's a lot of confusion out there on should I, shouldn't I? Well, if I don't, can I go here, go there? And I just heard, like I said, this week, someone say, no, you didn't need to vaccine coming from a doctor.
All right, here's what I'm going to tell you. Remember what we said on April the 30th last year about this disease?
Wait a minute. Did you hear what?
I've slept once or twice.
I was going to say, no, what did we say April? I remember what we said the week before that, but April 30th.
What we said then is not true today because we've had a year of experience.
I will go with that. Okay. All right. I see what you're saying.
One. So, the natural occurring disease, it is my opinion that guy's memory, B cells, and T cells are imprinted with this, and that it very well may give him better immunity than the shot. But the point is, we don't know that. We have no idea. And so to pronounce that this is the facts rather than this is a very reasonable theory goes beyond what we're able to prove. And that's why we continually are monitoring people. There are myriad, and I think even Ray brought up, why do you want to get immunized if you go back later and test and the people are carrying the virus? Remember, we talked about that each week. Yeah, they're carrying the virus, but they ain't passing it around to anybody. But we don't even know that until we've got more time behind us.
And the monitoring is intense.
It's intense.
There's more monitoring going on in this vaccine than I've ever seen on any vaccine.
Steve Marlowe is down there doing genetic sequencing on the variant from one of the people in this big research thing he's got that had the disease and was immunized. So they had disease, is immunized, and then they do surveillance cultures, I think every day. I think I told you about that too. 4 different places: the anterior nose, the deep nose, saliva, and the throat. And the throat's the most. You may have 3 negatives and your throat be positive. So they're doing that every day. They got so much data that I don't know how they can get a computer to analyze it. But what I'm saying is we really don't know the answer to that. I think that the vaccine right now should be emphasized in overweight, diabetic, elderly, that group of people. But as I said last week, and we didn't ever show that graph last week. One of the reasons that you would immunize people who are young and don't particularly want to be immunized is the graph I had that you were over there, and I got you to bring it up. I said we're going to show it. We didn't show it, remember?
Yes.
Okay, so it's easy to understand. So you have one infected person here. If the R0 is 2, then they infect 2. The next then is 4. The next is 16, and the next is 64. So in a week or 10 days, one person can infect 64. Now, if you got a really virulent variant that you're passing around, you got some serious problems there. So now just imagine that one person at the top comes in contact with an immunized person and a non-immunized person. Well, you've cut that whole tree in half just by this person up here having been immunized. It could have been a teenager. We don't know who it was. So throwing those immunized people into this thing stops that transmission in that big old graph. And that's one of the ways that you get a lower incidence of disease. Now, it is crystal clear in my mind that you will not get more than about 60 or 70% of the population vaccinated.
I'm very confident with you on that. I mean, and you look at the healthcare personnel those are people who have faced this disease for a year. About 40% of them are rejecting the vaccine.
Well, let me say
so to expect the general population to go beyond that is something else. Now, I will say this: the encouraging thing is that in the elderly, at-risk population, I would say more than 90% of them will get vaccinated. Almost all of my patients have. I don't fuss about the few that say I'm not doing it, but at the end of the day, to me, we are selling a product, and that's the vaccine. And every time we go off in the woods about, well, this one particular person or this person who had the disease, we need to argue with them. I mean, they beat up Joe Rogan because a 21-year-old healthy girl said, should I get the vaccine? He said, well, I don't know. I don't think so. And now they want to cancel him. But that's all a distraction. This is a marketing thing.
yes.
Can you get the group that's highest risk vaccinated? Can you get all those who touch that group vaccinated? And then everybody else is gravy.
And that's touching the group is the place where I'm talking about that big old group.
Well, let me say this off what you're saying. Now, I do remember it's coming back to April of last year is coming back to me now. Okay? And what I mean by that is I remember sitting right here April last year. We were still trying to figure out exactly what the virus would do to people, but when we were talking to Dr. Marlowe
every week,
this had an enormous infection rate.
Yeah.
The infection rate was so enormous. It wasn't so much like, how many will die. We were still determining what the virus would do, but the infection rate was so high.
Right.
Well,
It's
predicted so high.
2.5 million. 2.5 million are going to die in the United States was the original prediction.
Right.
And you remember what Dr. Marlowe said. He said, I see that on a much less order of magnitude, and I think he probably hit it right or a little bit less, more in the range of 500,000. Now, what's the number now?
It's 500-ish thousand.
500 now. So it's going to be more. But it will be 2.5 million. So things we've learned have gotten.
Well, wait a minute. Now we need to count annual deaths. You can't just keep counting forever and say, okay, well, we have date numbers on how many died in a year.
Yeah.
And his number is good. I mean, if he said 500,000 at the end of the year, it was 350 or something thousand. So that's a good number. Now, by the way, the people that study this are saying a third of those deaths died with, not from COVID.
Yeah, absolutely. Yeah.
Well, wait a minute. I want to go back to one thing, but the vaccine has definitely changed the infection rate.
Oh, totally.
Right.
You see all the curves are diving.
Right. That's what I'm saying. Is last year the infection rate we were talking about?
All right.
Go ahead.
Okay.
Go
You
ahead.
just said died with, not from. Now I want you to look. We're not going to go through a whole bunch of the news here, but read that right there and see what that says.
CDC to issue guidelines as long-haul COVID numbers rise.
Okay, about a month and a half ago, you remember way back in the spring and summer of last year, I said athletes should not go back to play after they've had the virus,
Right.
until they have had a history by a physician. And if there are historical features about their history, they need to have a echo or some sort of heart thing because of the heart issues. As it turns out now, about 10 to 12% of people who had clinically sick COVID have a long haul issue. I had a patient in the office yesterday who's back to playing pickleball. She's 86, by the way. playing pickleball, and she was going over to her bowling league, and she takes chemotherapy for ovarian cancer, and she had COVID. So here's a 80-year-old woman on chemotherapy who had COVID, who's playing pickleball and bowling. So she recovered. She still can't smell, she still can't taste, and it's 5 months out. Well, I don't worry about that one. But the ones that have confusion and have actual cognitive deficits and so forth, some of them may be like the people with fibromyalgia and zinc
Well, let me
deficiency
hit on
and
that, because
stuff.
this is a real primary care issue.
Totally.
So, I mean, you can't use your personal experience as a study, but I'm not seeing it. Okay, now some of my elderly patients or my lung patients, I see some post-COVID stuff. I'm not seeing in my younger patients some of the stuff I'm reading about. I'm not saying it does not happen. I'm just personally not seeing it. You mentioned chronic fatigue syndrome.
Right.
Well, that's thought to be secondary to mononucleosis, or a chronic or a viral acute infection that affects somebody for decades. Okay? And it's all over the place. Chronic fatigue syndrome is one of the bugaboos of primary care. Back pain and chronic fatigue syndrome are the two things you hate seeing walking in your office, because there's not much we can do about
Well,
it.
that's exactly why I brought it up.
I've had
Wait,
people say after COVID that they're just exhausted now.
Correct. That's true.
Just exhausted.
That's right.
But that could be any other virus could do that.
Okay.
Yeah, okay, particularly, well, I'll give you, you remember now, I've treated a very famous basketball player. We're not going to violate his name now, but there's been many movies about it, who played for Atlanta, had mononucleosis, returned to play the next year, had a less than stellar career, went to the Utah Jazz and was an all-pro for the rest of his career. I also had a hockey player like that. I've told you before that the difference between Michael Jordan and the rest of the NBA is 1/100 of a second and 1/10 of an inch. So when you have a professional athlete who has had mononucleosis, in the military, you're only out of duty one day if your spleen's not big, because you can go back to work. And if it's us, we're back to work. But if you're a professional athlete, you might be out of whack for a year or longer because of this. So that's performance. So anything below that can be said as fatigue, or I'm not sharp
Cloudy in my
mind.
thinking. I'm not as sharp. I'm
But
not paying
what I want to
attention.
get back to, what I was trying to get to there, is that we don't know how much of fibromyalgia and chronic fatigue and these other things are psychiatric versus real. And so when you've had COVID and everybody has treated you like a leper, and you get better, and you already got some underlying neurosis, depression, anxiety, then you got post-traumatic stress disorder from having had COVID, so to speak, and that then is a long-haul emotional symptom. But what there are here, there are 60 centers in the United States now, all of them in academic medical centers, that are focused only on long-haul COVID, and they can't see the patients. There's so many of them that have chronic lung disease. If you've got patients that have had COVID and were never sick, I just ran a fever, excuse me, not never sick, I ran a fever, I had a headache, and I coughed for 2 days, and you do a CAT scan on their lungs 6 and 8 weeks later, you're going to see ground glass stuff in the lungs of many of them. And they don't even know it because they're not chopping firewood or doing construction work. They've got something in their lungs. So the fact that we're not recognizing it doesn't mean it's not there. People's activity level may not be enough to where their diminished heart ejection fraction is causing them a difficulty. But these clinics are focused on people who actually are sick. And there's one at Emory, there's one at Grady, and they're everywhere. But there are none in the community because of the amount of resources it takes to bring together all of these specialties that you've got and have somebody to do the work. Who's going to do the work? Medical students and residents, Otherwise, there's nobody there to see them. So this we're not going to know much about for a while.
For a long time, years.
Yeah, but CDC is going to come out with something, and it's going to make all of us mad. I guarantee you that. So, but it's just another one of those things about we may all need a booster that have had the shot, and the guy that had COVID may need a booster, but we're not going to know that until this data has been found out. And right this minute, the guy that want to take the shot after having had the COVID, I wouldn't tell him to do it. But if he's worried about it,
Yeah, if he's worried about it, his instincts say,
give him the shot.
give him the shot.
He should make that decision himself after talking to his doctor and watching Fauci on TV and the other talking heads. Excuse me.
Whoa.
Yeah, went to
I want to throw out a number, 1.8.
1.8.
That's the number of people annually that die of tuberculosis. Million worldwide.
1.8 million worldwide died of tuberculosis.
And so worldwide, we're approaching 3 million COVID deaths, of which 1 million may be with instead of from. So COVID has exceeded tuberculosis, but tuberculosis has been killing almost 2 million people a year worldwide, year in and year out.
Yeah, but that's a tiny percentage of what it was doing in the 20s, 30s,
That's
40s,
what I'm going to go with this.
50s.
Okay, so take that number, which is a small number now, multiply it times 100. You got some serious numbers there.
Look
Okay.
at smallpox.
Yeah.
Look at
I have
measles.
I have a quick question. This is not to upset you, but we're tired of the confusion. We're just tired of it in America. To mask or no mask? That is the
Okay, so
question.
that's why I threw
All right.
this number out.
All right,
Okay.
CDC. All right.
Don't say what they say. Don't confuse us.
I wanted to. You're easily confused.
Yeah,
aren't you?
what they mean to confuse.
No, Bill de Blasio says, I'm opening New York City July 1st. Off what data? I don't know what he's used, but he's opening July 1st.
It's the people
CDC
that
said
flee in
we
New York.
we can come out and have small gatherings with no mask outdoors if we've had the vaccine. I think myself, we are so tired of that. And these people making decisions based on what? So
Okay, so the reason I threw out the TB thing is that you multiply that times 100 years. We're talking about 100 years. You're talking about over 2 billion people. Okay, easy. Okay, we live with TB. We treat TB. We have treatments for TB in poor areas. In this country, we don't even worry about it now. Okay, COVID's going to be similar, but even less. Okay, we're going to beat COVID. It's already on the downfall. Right now, COVID in this country, I'm going to say what is obvious, is less than the flu as far as hospitalizations go in a bad flu season right now. Okay, so why would we have a mayor saying for 2-year-olds to wear a mask? Why would we have sports coaches telling somebody to practice and run a race with a mask on?
Can't do that.
It's obscene. You know, in Oregon, there was a young girl who running a half-mile race fell on her face over the finish line from struggling with a mask on. Now, if I was her father and she messed her face up or split her head open, I'd be going after somebody. I would be, because there's no reason for that child to have to wear a mask, and there hasn't been for children, and for them to be wearing masks now is obscene. So protect those people who are at high risk. They should wear a proper mask when they're in an exposed area, and everyone else get the mask off. I don't care what these politicians, what I call tyrants, say. We're outliving our lives now. The elderly need to protect themselves, self-protect, and only the elderly that are not getting vaccinated. And all this other business, it's simple. Throw them away. Have a little party. Have a mask burning party.
Yeah, but I want to
All
give
right, now-
I got to
Go ahead.
you said you got to hear it now. Road rage. 2 of us are trying to get the same parking space at the Walmart, and we're arguing about it, and one guy gets out and shoots the other one. We're familiar with this in Vermont or New Hampshire, I don't know which state it was, about 2 weeks ago, because I saw the video, in a place that was a low rent sort of a store, could have been a thrift shop or a dollar store. There is an older guy with a mask on one side of this narrow counter, and a looks like Jeremy on the other side without a mask, and the guy with the mask is chewing the guy without the mask a new one. He said, please, sir, I'm only getting a pack of cigarettes. I'm 25 years old. I got no chance of dying of this disease, and I don't want the people in Washington telling me what to do about the mask. And they argue a bit more. And the older guy pulled out a pistol and shot the guy. Now, he didn't kill him. I think he whipped him in the arm. But the point is that he got to the road rage place over wearing or not wearing a mask. So here's what I'm telling my...
you know why they got there?
Okay, but let me
It's
finish.
because of the people on those big
Okay,
screens.
all right, here's what I'm telling people. They're there. So they're there. I can't help the fact that they're there. Well, I use this analogy, and I think I told you the other day. If I go into Walmart and I've got my flying zip, it's going to make people uncomfortable. They're going to want to know that should they come talk to me. They don't know that I've had a vaccine when I'm in Ingalls. So when I go in Ingalls, I'm going to put that boy on just so people don't get mad and some big guy that's had a couple of beers doesn't come smash me in the mouth. So I'm protecting myself only from criticism and from getting hit in the head. This isn't protecting me from anything, including the pollen, and it's not protecting you from anything except making you uncomfortable and hoping I don't get hit in the mouth with a balled up fist.
And who caused that? And I know who caused that.
Well, you know who caused that, and we'll ask this question. So, with Dr. F between us. Okay.
All right. That's
when you poll American public and you ask them, if you get COVID, how likely are you to be hospitalized? The number is less than 2%. Likely to be hospitalized.
People think it's 40.
People think it's 40, 50, 60%.
40%.
And so their notion of this disease is so distorted.
Yes,
and that is the media propagandizing nonsense.
The number is actually 40%. If you just ask the great unwashed, if I get COVID, what's the chance I'm going to be great unwashed? That means out in the parking lot. What's the chances that I'll be sick enough to go in the hospital? It's 40%.
all right.
But the real number's 2.
Yeah, it's less than 2.
Yeah, less than 2%.
Right, it's probably less than half of 1%. But anyway, it's a tiny number.
We have to get out. We got to wrap this up. You got anything you need to close with?
I'm sorry, I didn't bring any good humor today.
Why do
Nothing?
we have to wrap it up?
Because those three might bop us in the nose.
In the green room.
Yeah, they're over there waiting. They might.
They're running out of bananas.
They might be like the
road
guy.
rage.
Yeah, they might have road rage over there. And you? Anything else?
No, donate blood. There's a huge need for blood.
Folks, this has been Ask the Doc with Dr. William Whaley. We thank him every week for preparing on these questions that you send in, and our friend Dr. Raymond Tidman. We want to thank always Georgia Cancer Specialist affiliated with Northside Cancer Center. We appreciate them for this segment. If you will go to FYNTV.com, you will see Ask the Doc. You click on there, you get all of these segments. You can share with your family and friends. Also, there's information, Northside Hospital. There's a lot of information there that you can get concerning Northside Cancer Center. Right there on FYNTV, Ask the Doc. Share these with your family and friends. And you can always send Dr. Willie a question, info@FetchYourNews.com. Put in there, Ask the Doc, or follow us on social media, FYNTV, Fetch Your News. We're going to take a break. We're going to come back. All-star political panel. Guys, thank you very much. We got to get them to work, okay? Take a break.